Hello, everybody. Good afternoon. Welcome to a afternoon edition of Clinical Problem Solvers Video Morning Report, where we get to listen in on a case. And I'm so delighted. I actually see a couple. Sarah is one of my medical students who's joined today, so I can recognize someone here. So great. Hopefully we learn from this case today. And I'm so delighted that Mary, one of our VMR Academy leaders, is going to present a case. So I am just so eager and very excited to hear about this case. But Mary, you want to talk about it? What's going on with you this summer?
Yes, thanks, Dr. Ravi. So I'm Mariana. For those who don't know me, I'm an Academy member. I am actually a Brazilian medical graduate, and hopefully I'll be applying for internal medicine match this year.
Wonderful, wonderful. Lots of luck to you. And we have a lot of exciting sessions that are going to be happening in August. I just reached out to Dr. Dobin Chow, who'll probably talk about the personal statement. And then we have a few other sessions that hopefully will help you with compiling your application for ERAS, and also everybody else that's out there. I hope we have a lot of sessions that will help you be successful in your match this year. And I'll have Sosan. Where are you? How are things going with you? Oh,
Oh, sorry. Can you hear me?
yeah, I can hear you. Yeah, how you
Oh,
been?
sorry. Great so far. Yeah.
Okay, awesome. And we have Heemun. Heemun was also at Neuro VMR this morning. A very intense discussion and also a case this morning. How you been, Heemun?
Yeah, I'm so happy to the teaching point and very excited for a Mary case.
Hey, awesome. All right, so we have a small group. What we'll do is let's seek guidance and maybe input from the group, and we'll see what Mariana. This is a second case, so very excited for her to present today, and we'll see what she has in store for us. So, Mariana, the first aliquot, please.
Okay, so for the first aliquot, we have a 47-year-old female presenting with dry cough and mild shortness of breath for 3 weeks. So patient refers that she started with a dry cough around 3 weeks ago with no associated fever. At that time, with 5 days of symptoms, she was prescribed azithromycin for 5 days for presumed community-acquired pneumonia. Symptoms got slightly better after the medication, but returned around 1 week later, associated with progressive shortness of breath. Now she comes to the ED due to persistent cough for 3 weeks, moderate shortness of breath on exertion, and low-grade fever. Review of symptoms is negative for nausea, vomiting, or diarrhea, but she mentions progressive fatigue.
Very interesting there. You mentioned cough and what kind of I'm thinking about at this point. It is one of the most common presentations to outpatient clinical settings. So I think for primary care providers, they do come across cough quite a bit, and having an approach to cough is very helpful. As a hospitalist, when I see cough, I start thinking of probably ominous things here, but if I enter the mindset of the person who's seeing this patient in the outpatient setting and having this cough, 3 weeks is quite a bit. So we're kind of moving away from acute presentations to maybe more subacute presentations. So what kind of things can cause cough? So we start thinking about maybe the most common cause is a viral sinusitis. And then also what you could also have is postnasal drip, which I think is now upper airway cough syndrome. And then there are a couple other things that can occur, like a non-asthmatic eosinophilic bronchitis is one of the things as well. But then you also have to wonder about drugs, and ACE inhibitors are common. We always have to think about ACE inhibitors maybe causing a cough if the patient's been recently put on an ACE inhibitor. So it's usually within the first 2 weeks, but it can have any time frame. So those are sort of the things I'm thinking about, and also have to wonder about what time of year is it? So if it's in the spring, you have to start worrying about allergies and things like that. Initially, without any fever, without any dyspnea, I'm not so worried. But when you introduce other parameters or other symptoms like fever and shortness of breath, I start to worry that there's something else going on. And just by giving an antibiotic at the beginning, azithromycin, not very good for strep pneumo. There's burgeoning resistance, but it used to be a very good antibiotic for upper respiratory tract infections. Mycoplasma is also a common cause of upper respiratory tract infection as well. So it would be very good for that. Atypicals, but if we're thinking about maybe pneumonia, a lot of people are probably starting to think, well, hey, what if there's a pneumonia here? And with the exam, it would be more elucidated with abnormal lung sounds, vital signs where you have tachypnea, you have hypoxemia, maybe that would clue us in to maybe a lower respiratory tract infection. But with the azithromycin, patients not feeling better, then you have to start thinking about, hey, maybe there's something else. So if we step back and look at it like with a dragon eye fly view, looking at possible conditions to think about. So inflammation, infection, we kind of moved away from. It still could be in contention, but inflammation and maybe other causes, you can start thinking about autoimmune conditions. 47 is ripe for maybe autoimmune phenomena at this point. And malignancy is kind of not the time frame, but I also would want to start thinking about maybe the social behaviors. Maybe is there any vaping, smoking, anything like that could actually introduce other complexities to this case. But let me search for the chat here, see if there's any other input from people. Hans, do you want to unmute for a second? We have a small group, so we'll kind of gauge from the crowd. You have a couple of points there which are interesting.
Yes, I mean, I got an idea when I listened to you explaining the case. Besides viral infections, which probably might apply here, we were at first thinking about bacteria, azithromycin. Maybe it was the wrong antibiotic for the wrong bug and it's still bacteria, or is it viral? Is it affecting the lung? Is it affecting the heart? Does she develop something like a myocarditis, which slowly and insidiously gets worse? Or, and then the final thought was, if she's vaping, then EVALI, this evaporation associated lung injury, looks very much like an infectious etiology. And all of these have to be ruled out until we can finally diagnose EVALI as the reason and treat it appropriately with, I think it is steroids in this case. So at this point, everything is possible. We need the past medical history and the social history for sure, and a good physical.
Absolutely, absolutely. So it's interesting. We talked about, so you got acute cough, subacute cough, chronic. So subacute is 3 to 8 weeks. And we talked about a variety of different things. I think Ethan had compiled a nice list of upper airway cough syndrome, ACE inhibitor use, GERD, asthma. So these sort of things would be common, but I think we're moving into the domain of something that may be a subacute infection. Now, this patient's coming back, although they got a dose of zithromycin. But zithromycin, again, is not a great antibiotic to give first line for somebody if you're thinking they have a lower respiratory tract infection or bronchitis. But I'll swing the mic back to Mariana for the next aliquot.
Great discussion. So for past medical history, the patient was diagnosed with HER2 breast cancer stage 3. She underwent chemotherapy with docetaxel and carboplatin for 2 cycles, and then trastuzumab was added for 8 cycles. Her last chemo was finished 1 week before the onset of symptoms. Radiotherapy was also performed alongside chemotherapy. 9 sessions were completed, and the last one was performed 5 days before the onset of cough. Patient also has diabetes type 2 treated with metformin and hypertension treated with lisinopril. Patient is from Puerto Rico. She moved to the US 25 years ago. She does not smoke, does not drink alcohol. She has no known allergies.
We can stop there. This was a couple of interesting points. Anybody have any ideas or want to unmute and discuss? We were wondering about social history, past medical history, and this adds another layer of complexity. Oh, Hans, again, you're kind of thinking what I'm thinking, but you want to unmute and share your thoughts?
Somebody else, maybe first. When I heard chemo, I thought right away about side effects of the chemotherapy. Maybe she developed metastasis to the lung. I think the breast cancer likes to go to the lung first. And then, of course, she's immunocompromised. So everything that applied at the beginning about bacteria and viruses definitely applies now as well. So those were my ideas.
Oh, absolutely. Yeah. I love the thought. Could there be side effects of the treatment that was given, and also then this notion of immunocompromised status? So the ball game it does change in such a patient being immunocompromised secondary to the treatment. And this was 2 cycles. So chemo finished 1 week ago, recently. So patient, you're absolutely right, is immunocompromised. So coffin immunocompromised patients, you have to start thinking about other sort of infections. So different things that can cause infection, like fungi, PJP notoriously could be something that could be causing infection in this patient. Varicella, so viruses like varicella, herpes virus, CMV could also be at play, and then not to mention the conventional influenza. It depends the time of year. So influenza, COVID, and so on. RSV is also part of this triple cocktail of URTIs now that are ravaging the nation or the world at this point. So some certain things you have to think about in association with this condition of breast cancer. You also have to think about a hypercoagulable state. So PE is also something in contention. But at this point, I'm not getting the idea that this patient is deathly ill. But again, this is a patient initially presenting at one time and could get sick later in the course, as Mariana continues to give us the next few aliquots. Anything else? Oh, Austin, are you able to unmute? I like what you have there.
Yes. Hello.
How are you doing?
I'm doing all right, thanks. I don't have a ton more to add, I guess, beyond what I mentioned there. But recurrence of the or new metastatic disease to the lung can cause all sorts of respiratory symptoms. Malignant pleural effusions, super common with breast cancer, and can manifest with cough from pleural irritation. I'm not really aware of a paraneoplastic phenomenon that would directly cause cough, but that's just something I always think about in anybody with cancer. And then some of the particular treatments she got as far as how they can impact the cardiopulmonary system. Trastuzumab, well-known association that is board tested pretty often. And then I believe I heard that the radiation was relatively recent compared with her symptom onset. And so I'm not a radiation oncology expert, but perhaps the time course there could fit with some sort of pneumonitis or something like that. And then infections have already been discussed at length. So yeah.
Yeah, absolutely love that. Yeah, the radiation could have a role to play, and pneumonitis would present with, at least I would suspect, having that much diffuse disease, somewhat of an AA gradient. So I think in this case, a exam would be really beneficial. Sometimes you do exams and you don't see a lot, and imaging will be the key in this case. But I think what really will help us make progress is the exam, and especially with the lungs. There's so much that you can get from the examination of the lungs. So definitely listening. So when students do what's called an SB exam, you get points taken off if you don't listen to the back as well as the front. Also, egophony, and then percussion is vital. I love percussion. Like Austin mentioned, pleural effusions. You may get dullness to percussion, whispered pectriloquy as well. So you want to also palpate for any difference between both sides when taking in a deep breath or saying saying 99 or something like that. and then the egophony, also the E to A change that you may get as well. So that can be very helpful to discern if there's a infiltrate. So is there something in the lung? Is there something outside the lung, like a pleural effusion? Is there something that's disseminated within the lung, maybe a fibrosis or an infection? So there's so much that we can get, and I'm really excited to see what the exam yields for us. And then also, yeah, Austin, doing a POCUS. If you have a ultrasound that's handy and available in the emergency room, just doing a POCUS and then looking for, first of all, lung sliding is very helpful. And then what is I'm trying to remember the protocol that we do, rush protocol. So pumps and the pipes, and I guess the vessels, I forgot what the pump pipes, vessels, yeah. So look in the vessels for maybe a DVT, looking at the pump, the heart. So if there's any LVF abnormality, pericardial effusion, and then the pipes are looking at the lungs. So looking for lung sliding, looking for pleural effusion, looking for B lines. That could also help you in trying to determine your hypothesis, whether you have pulmonary edema or maybe a pneumonia or something like that. Back to you, Mariana.
Fantastic discussion. So moving on, temperature was 38.1, blood pressure was 135/78, heart rate was 88, and saturation was 95% in room air. She was in mild acute distress. Pulmonary auscultation revealed mildly decreased breath sounds in both lungs. Cardiovascular was normal rhythm with normal S1 and S2. Abdomen was unremarkable. Neuro, she was alert and oriented ×3, no focal deficits. On extremities, she had no edema and no rash. For labs, she had a white blood count of 4,500, hemoglobin of 9, platelets of 141,000. CMP was unremarkable. AST, ALT within normal limits. Creatinine was 0.8, and urea was 26.
Very interesting. I was sort of hoping or pinning the exam to yield us something, but the exam's not really remarkable here. Although what's very remarkable is the vital signs, that there is a temperature, so we have to start thinking about infection versus inflammation. And because the exam's not really yielding a great deal, or maybe a focal abnormal finding, such as diminished breath sounds in one area, the lower lobes, or crackles or wheezing or something like that, just globally diminished lung sound. So maybe this is a bilateral pulmonary process. And I think we have to then start thinking, where do we invest our cognitive strategy in trying to get to the answer rapidly? So if we see this patient, and this is commonly seen in the emergency room, you will see this as an intern, attending, resident, medical student, and somebody presenting with this, and the AA gradient's not too bad, 95%. So SpO2, 95% will be about, so 60 is 90%. PaO2, 60, it's probably 65, probably close to 70. Normal PaO2 would be 70, 80 on FO2, 21% on room air. So diminished breath sounds, I just wonder if there's something fine that's going on within the lungs. And going back to the hypothesis that Austin mentioned about possible pneumonitis, that sounds very interesting to me at this time. But still, I don't want to just put all my eggs in one basket to just think about this condition. But imaging definitely will be helpful. At this point, because we have a small group, why don't we just split off into rooms? That way we can maybe think about this a bit more. So I'm going to set up recording. Okay, welcome back everybody from your breakout rooms. Hopefully you all had an engaging conversation. I'm going to go through, I think 3 rooms were occupied. So I'll start with the first room, see what you may have discussed there. So in the first room, I think Mukund was there, Favor was there. Any one of you able to unmute and maybe share with us what you had discussed?
Sure. Yeah, so we had a very, very interesting discussion. Thanks to Austin and Mengyu and Favor. I think the key takeaways here are that the differential is still quite broad, but that the sensitivity of the auscultation for any reliable finding is still quite low. And mildly decreased breath sounds could, if this were true, imply effusions, although unilateral will be more expected than bilateral in this situation if it is malignant, but could also just be a result of poor air movement, could be a result of obesity, leading to impaired kind of auscultatory sound transmission, or could just be a more subtle process without more in-depth pulmonary imaging. I think it's hard to make a lot of progress.
I just love that. It's a very subtle finding. So you're right. Yeah, when you do have abnormal lung findings, it does help us. It's almost like the catalyst to help us move towards a diagnosis of what kind of imaging you want to help you in trying to make a diagnosis. But yeah, it's a very subtle feature. So maybe there's something else that we need, maybe more high resolution, such as a CT. So I always have this difficulty doing an X-ray or just going straight to a CT and getting a result. Will the X-ray, because the finding is so subtle, will the X-ray be good enough to try and find us an answer? But I'm thinking the CT will be helpful. I'm going to move to room 2. I think Sarah was there, Vinicius was there. Anybody able to unmute and share what you had discussed?
Yeah, so we don't think that we have a lot of to add, but because we already discussed. But another thing that was discussed also is about the possibility of dilated cardiomyopathy secondary to the chemo episode. But maybe we're just like picking some possibilities and bugs, but everything points to the image and the CT. So we will have a better understanding of what's going on.
Absolutely, yeah. I like the thought of maybe there's a cardiac involvement as well, and just sort of reminds me from the get-go we could have utilized a schema. So sometimes trying to explore the causes, a schema can be helpful in trying to solve the problem. So the problem is that the cough and then dyspnea, now this fever. So it very much does highlight possible infection, inflammation. But this dyspnea pyramid is a very common and useful schema for students. And in that, like you had highlighted, yeah, is there a pulmonary condition, cardiac condition? There is slight anemia, so blood does come into it. I think it can cause some of the dyspnea, and especially anemia doesn't cause a very low SpO2. But then again, I don't think it's the answer, but it could be just contributing as well to this presentation. And then one with room 3. Abul Fazi, how are you doing? I haven't heard from you in a bit. Anything else that you want to add to the conversation?
We were generally along the same lines. Effusion first, especially in effusion due to a malignancy effect, then a cardiac condition, and alongside both of them, an infection that is just presenting this way, like everything that can cause the symptoms just due to the infection.
Absolutely wonderful, yeah. And I think you mentioning exactly what we were initially exploring, this infection is also because of the fever. I think it's pretty much still in contention and high up on our list of possible causes. And at this point, I think definitely imaging is the order of the day. I'm going to swing it back to Mariana. Maybe if there's any other labs before we get to the image.
Okay, so we had some infectious workup. Influenza was negative, COVID was negative, bacterial, fungal, and fungal cultures and other workup for virus were collected and are pending at this point. HIV was negative. CT chest showed bilateral peribronchial thickening and interstitial infiltrates consistent with bilateral multifocal pneumonia. There was no signs of pleural effusion. Echocardiogram was normal with a left ventricle ejection fraction of 60% with no valvulopathies. At this point, patient was treated with corticosteroids. She was started on empiric antibiotics with vancomycin and cefepime and Bactrim prophylaxis.
Very interesting. I'm going to open up the chat. With the image, well, let me just admit. All right. With the image findings, definitely does sort of fit the picture we were thinking about pneumonitis versus an infectious interstitial process. But any thoughts before we move forward? The antibiotic choices are certainly interesting. It's very broad spectrum coverage for a patient that's not terribly ill. But I guess just having been on Zithromax or azithromycin, you do have to put that rule in. If the patient received antibiotics within the last 90 days, then you may have to cover for more multi-drug resistant organisms. So hence the vancomycin, cefepime. And then I don't know about the fungal coverage, but at this case, yeah, the vanco and cefepime, and maybe still atypical coverage. Well, the patient was already on zithromycin, so less likely the patient got enough coverage. Any thoughts? Let's see, Vinicius. That's a great thought. You want to unmute and share your thoughts?
Yeah, so basically she was already prescribed and the azithromycin at the first glance and did not result in any improvement. So we, the medical team basically decided to escalonate the antibiotics. And well, the thought right now is we are covering gram positives, gram negatives, and like in using the Bactrim. So if she doesn't improve right now, I would think that some fungi that is maybe it is a decent thought to this chemo scenario. Basically that.
Yeah, absolutely. Yeah, if the antibiotics do not get or do not help in getting the patient better, although some of the antibiotics also do exude some anti-inflammatory effects, and zithromycin actually is one of them. So it has an anti-inflammatory effect. Some of these antibiotics can help as well. So sometimes patients will get slightly better on these antibiotics, but that doesn't solve the answer. It doesn't take care of the issue. So, but what I would do with this patient is do at least a MRSA nasal swab. Has a very good negative predictive value. That way we can get vancomycin off cefepime, covering most of the gram negatives, Pseudomonas, and I guess the Bactrim for PJP, and doing testing for PJP will be helpful in trying to figure out what's going on with the patient. One thing I kind of neglected was the white count. The white count's not terribly high, but again, in this patient we identified, as Hansa mentioned, is immunocompromised, so we don't anticipate a white count in this case. But the patient has had a fever, so they definitely are responding to whatever is going on, which we namely were thinking infection. Back to you, Mariana. How many more aliquots?
I have one more aliquot, and in the next one, I will reveal the diagnosis.
Okay, yeah. Austin's mentioning, yeah, it would be very helpful, especially if we're thinking PJP. Doing a bronchoscopy would be very helpful to see what we can gather from the alveoli and get an answer for this. All right, back to you, Mariana.
Okay, so viral PCR was positive for enterovirus, and at that point, patient was clinically stable, after 5 days of hospitalization. She had a saturation of 96% and 2 liters of oxygen in nasal cannula. She was discharged home with oral antibiotics and oxygen after the 5 days of hospitalization. But she returned 7 days later with worsening shortness of breath, cough, tachypnea with a respiratory rate of 38, and a saturation of 88 in 5 liters of oxygen. And she also mentioned low-grade fever that was noticed at home. Due to signs of respiratory failure, she was intubated right away after the second admission. Another CT chest was performed and showed ground glass attenuation associated with traction bronchiectasis consistent with severe acute respiratory distress.
Wow. That's definitely a change of events. And especially, I always get nervous when patients leave and come back worse. So we weren't able to get the diagnosis and help the patient get better. And it's devastating when somebody leaves and comes back because we weren't able to identify what was going on. But sometimes it happens. Sometimes even in the hospital, patients get worse and then they disclose what they're having. So sometimes the whole features of a case won't be evident until they get very ill, which kind of reminds me of I had a patient with mild hemoptysis and pneumonia, and 2 weeks later had renal failure, glomerulonephritis, and hence we were able to diagnose Goodpasture syndrome. So it does kind of take time for a patient to disclose what they're having. But with this patient returning back very ill, if we go through the sequence of events, the patient has gone a good number of different antibiotics, was treated somewhat better, went home, now came back, and now is tragically very ill, requiring intubation. So whatever process was going on has just amplified and taken over the lungs, and this A gradient has become so humongous that the patient needs mechanical ventilation and probably pressure to move that oxygen through the lungs, increase alveolar recruitment, and also increase the FiO2 available to oxygenate the lungs and the blood. So this, I'm very interested in with this new CT, when I'm not seeing this picture of like a ARDS, what could happen in the time frame? ARDS could happen, and although with this PA2 FiO2, maybe the patient is meeting Berlin's criteria for ARDS, but we're not seeing that bilateral sort of pulmonary edema kind of process, but with a low pulmonary capillary wedge pressure. So what we're seeing is a lot of ground glass and a lot of sort of this traction that's happening. So again, that kind of brings features of maybe, but one area we haven't really explored is fungal infections, plus or minus inflammatory conditions. So is there a coexisting inflammatory condition? Sometimes infections can potentiate and cause post-recovery inflammation. COVID has notoriously been associated with that. So post-COVID lung inflammation can happen. But I think Abul Fazi, you've noted something interesting. You want to unmute and discuss what you put in the chat?
So we're seeing GGOs which is showing that the alveoli are half filled with something, and that something can be described as pus versus blood versus water from an etiology that causes pulmonary edema, like the underlying malignancy that we were seeing, pus from an infection that we missed, or an immune reaction to the infection that has gone out of control, and blood that can basically come from everything, like just damaged vessels pouring themselves into the alveoli.
I like this thought that you've sort of portrayed here with what could be filling the alveolar. And so again, we're going back to basics and thinking about, is the infection, is there actually maybe a vasculitis that's taking place with diffuse alveolar hemorrhage? Is there maybe cellular infiltrate from infection? So it kind of, at this point, I think what will help us make progress, I think Austin's already mentioned this, doing a bronchoscopy and BAL will be very helpful. Doing a lung biopsy, always, there's a lot of risk involved. So pneumothorax when you're trying to get a lung biopsy. But at this point, I think at least a BAL will be very helpful. And also then thinking about infections that, because this patient's immunocompromised, could there be other infections at play as well? So namely fungal, I guess less likely TB, but inflammatory lung disease is definitely something that I'm strongly considering. Back to you, Mariana.
Very nice discussion. So, okay, now I'll review the diagnosis. So patient was started on high-dose corticosteroids. Bactrin was changed from the prophylaxis dose to the treatment dose. She was also continued on vancomycin plus meropenem. So during her hospital course, she required increasing amounts of oxygen with no clinical improvement. She was even placed in prone position to try to improve her respiratory parameters, but it was very unsuccessful. So PJP test from the BAUL returned negative, but it was positive for Candida, so antifungals were started. Given her lack of respiratory improvement, she was ultimately placed on ECMO. She stayed on ECMO for more than 14 days with no improvement in respiratory parameters. So a BAUL cytology was performed and revealed malignant cells, confirming breast cancer with lymphangitic spread. So the final diagnosis was lymphangitic carcinomatosis.
Wow. Abul Fazi, we kind of went back to basics and we thought, what's in the lung there? And I really like that approach. And that approach definitely was able to help us understand what is in the lungs. And namely, one of the things, there was infection, there can be inflammation, but there was cells. And I think that's very helpful. We start talking about that early on in some of the cases, but going back to basics helped us to at least start thinking about what could be in the lungs. So I really appreciate you bringing that up. It was very helpful. And I think here, a very devastating case of lymphangitic spread. How did the patient do, by the way, Mariana?
Unfortunately, she passed away. It was very, very challenging to be part of this patient care. And I wanted to bring that because since the first admission, they didn't know if they were dealing with radiation pneumonitis or interstitial lung disease induced by chemotherapy, or if it was an infection, or if it was like advanced cancer. So there was nothing in the image that could point to cancer. So it was very, very challenging. They started her on high dose corticosteroids and she didn't get any better after that. So yes, it is a very unfortunate diagnosis, and it was very challenging to be part of this team taking care of this patient. But I thought we could discuss that and learn a little bit more about that. And another thing that I learned with this case, and I learned it during my rotation with the oncology team, is that as soon as a patient becomes a stage 4 breast cancer, you do not treat the patient with curative intent anymore. So until the stage 3, you treat patients with curative intent, but as soon as the patient becomes a stage 4, they would be treated with palliative intent. So that's what happened to this patient. So to treat a lymphangitic carcinomatosis, you should give patient chemotherapy, but she had already had like 2 lines of chemotherapy, and she was not in a good clinical stage to receive more chemotherapy. So we didn't have much to do at that point.
Thank you, Mariana. That's a very valid point. It's very difficult to treat a condition like this, and I'm really appreciative, and also remembering the patient, appreciate the patient for teaching us today, and for you putting this case together and bringing all this teaching to us today as well. So thank you very much. This is such a rich case, and unfortunately something we do see quite a bit in the practice of medicine, and unfortunately we're not always able to help the patient with, because again, going through the different infections we were thinking about, this ultimately was the cancer itself. And one interesting thought while you were going through your reflections was the steroids. So we talked about the patient was on antibiotics and didn't get better, but there is data now and a practice nowadays to use steroids in severe CAP. So there was the Cape Cod trial where they used steroids in severe CAP in the ICU, and there was actually ultimately patients have done better. Sometimes the ICU stay, the length of ICU stay also diminishes while survivability improves. So something to think about. So that neither the steroids, like you mentioned, neither the antibiotics help. Chemotherapy would be helpful in this case, but the patient went through cycles and cycles of chemotherapy without any resolution. So again, I thank you, and I also deeply appreciate the patient for helping us with this case today. Teaching points, Iman?
Sure, yes. Yeah, thank you for wonderful case, Mary and Ravi, and unscribing, it's awesome. Okay, so it's for a patient, 47 years old female with breast cancer, past medical history, present with 3 weeks of subacute cough and shortness of breath. We talk about how to approach 3 weeks of acute cough, and then because that person was immunocompromised state, we thought about some influenza or PCP, TB, CMV, and also hypocoagulability of a pulmonary embolism. So when we look at when we listen to the lung sound, we have to look at the dual or crackle sound for interstitial pleural effusion and like precordial effusion. And also we look at the CT, and there was ground glass opacity showing bilateral pneumonia. Even though the patient was treated with the antibiotic, the patient has to come back with a shortness of breath, and even like mechanical ventilation was necessary. And the VL cytology shows that breast cancer with a lymphatic carcinomatosis. Lymphatic carcinomatosis is usually happening with the breast cancer stage 4 because it's a palliative therapy, so maybe not enough chemotherapy. So the treatment was chemotherapy, and the patient had a poor prognosis for that. And also, we are considering about, after looking at the CT, we are considering about ARDS and fungal and TB and some pulmonary fibrosis and malignancy. And the malignancy, that when we talk about alveolar filling and the malignancy, the diagnosis was the lymphangitic carcinomatosis. Thank you so much.
Thank you, Human. Thank you for compiling all those teaching points and also presenting it so well. And again, Mary, thank you for presenting such a professional case, and also Salsan for doing the scribing. So take care, everybody. Thanks for coming. Bye.